Microcredit Summit Campaign and Freedom from Hunger have been working in India now for the last 10 years on promoting health on the platform of microfinance. And first 5 years, these two institutions work separately. Microcredit Summit Campaign mostly in the southern part of the country and Freedom from Hunger in the eastern part of the country. And later 5 years, we have formed an alliance and we are working together in promoting health. I am glad to let you know that now we have more than 20 partners, including microfinance institutions, SHG promoting organizations and state governments with whom we are working and reaching out to nearly 1.2 million client families with health promotion. Different organizations have taken up different health initiatives and it's going on and expanding day by day. But what we have noticed is, though we have been able to partner with many institutions and reach out to many clients, we have not been able to sufficiently enthuse the health sector to look at microfinance sector for promoting health. So we have decided to form a sort of a community of practice of these two sectors, form a consortium of health and microfinance stakeholders and see how these two sectors can learn from each other, with each other and benefit with this kind of learning. So we are just in the beginning stages of forming a consortium and but I realize that Philippines and in Andes the community of practice are much more advanced. So we would like to hear from Marilyn and Cassie as to how community of practice has been formed and progressing in these two countries. Marilyn, will you be able to share with us your Philippines experience and what kind of learning is there for us from Philippines?
Well, yeah, in late 2011, early 2012, of course, my organization, CARD, has been doing health and microfinance way back. But then during those years, early 2012, we realized that we can't do this alone.
Mm-hmm.
We need other microfinance institutions to be able to help us push the health advocacy in the microfinance industry, because microfinance industry has the mass base. We have millions of clients. We are talking about millions of families, millions of Filipinos, millions of people. And the best way to be able to reach that is to rally the support and rally the cooperation of other microfinance institutions. So being in the forefront of the microfinance industry in the country, we led a consortium. Right now we have around 25 members of the consortium who are sharing technology, technical expertise, sharing financial resources, in together providing health services to the microfinance clients in the country. Because by rallying the support and rallying the cooperation of these microfinance institutions, we are more or less assured that we are reaching the very poor, that we are reaching the majority of the population, because of the nature of microfinance institutions being in the community and mass-based.
Are these 25 microfinance practitioners or do you also have any health stakeholders of health?
All the 25 are microfinance institutions, but in each of the 25 institutions, each one of us have health practitioner partners. Like for example, CARD, we have around 1,000 partners who are all health service providers, hospitals, doctors, or birthing clinics. So what we do, we give them a very simple, no-nonsense partnership. We tell these practitioners that, hey, we have 1,000 or 5,000 clients in your place. We will tell them that you are a partner of ours. We will bring them all to you. We will give you the numbers, but then when these people come to you, give them discounts.
Mm-hmm, mm-hmm,
so that's very easy, and that's a very simple partnership with
working well.
And it's working well.
Mm-hmm. Good.
Marilyn, can I ask whether the government is getting involved in this massive program?
Okay, so not directly, but we are working with the National Health Insurance Corporation, and they consider the microfinance sector as an informal sector. So what we do, but not only my organization, but a number of other microfinance institutions in the Philippines. So what we do, we advance the payment of health insurance premium to the National Health Insurance Corporation, and then these clients would pay us back
Installments.
in installments.
The Feel Healthy program.
Yeah, the PhilHealth
Okay,
program.
good,
So,
good.
So it's a good partnership between the government, the microfinance, and the health service provider.
yes, and the government loves working with microfinance institutions because of the very nature of the mass-based MFIs.
That's a very positive thing, you know. I don't think it has happened so far in our country.
Is it financially sustainable or grant funds to support the program?
One of the things that really have encouraged the microfinance institutions to come together is the sustainability of the program. Because if you come together, there would be economies of scale. Like, for example, if we provide medicines, for example, there is economies of scale because we are many working together. So that's one way of bringing down the costs of the program and being more cost efficient, but at the same time reaching a majority number of the population.
Ever increasing numbers.
Ever increasing numbers.
Cassie, what is the status of COP in Andes?
Yeah, so I can give a little bit of the history. So the community of practice in the Andes, specifically Ecuador, Bolivia, and Peru, has been going on for about 5 years. And it started with this idea of Freedom from Hunger, had a variety of partners in those 3 countries doing microfinance and health work. And the idea was, well, be great to get them all together to exchange ideas. And, you know, maybe one partner was doing WASH and another was working with, you know, maternal health. How can they, and they wanted to learn from one another because they were doing different things around health. And so we had the opportunity to have some big gatherings between partners in those 3 countries and really talk about, okay, what could we create here? And then allow the partners within each of the countries to go back to their own country and figure out, okay, within Bolivia, Ecuador, Peru, what can they do within the country? What are the objectives, you know, of this community of practice? Who else should be a part of it? And so it really started with these microfinance institutions who are doing health. And, you know, the idea is and has been to figure out how to integrate health actors, which is sometimes easier said than done. But, you know, so I think in the past 5 years, we've learned a lot. Also, some of the challenges of having communities of practice. I think people say, oh, what a lovely idea. People can come together, share ideas. But a couple of things, you know, you need a champion and someone who can gather people.
Absolutely.
And Freedom from Hunger in Latin America has been that, but after a few years we thought, well, we want to support, but really it has to live within the country, within those who are participating. And so figuring out who can be that lead actor, and in at least Bolivia and Peru, some networks have stepped up. So Procosi in Bolivia and Promuc in Peru, who had a network of or different MFIs who are doing health and microfinance belong to that network, and so it made sense that they kind of take on that community of practice. So, you know, it's pushing them along, and then I think also, although everyone is really interested in the idea and they want to know, well, what's this institution doing and what's that, and people are very busy doing their own work, and so you really have to think hard about what is going to be most worthwhile if we're going to get people together and they're going to
How do
step
they see
out.
value in the whole thing?
Yeah, and so what do people want out of it? What when they walk away from a meeting, be it quarterly or annual, what's going to make them come back the next year? Because it's great to talk about what we're all doing, but people also want to walk away with something tangible. And so
Absolutely.
figuring out what that is, be it from health providers or microfinance institutions, what is it that they value that they will come back to that meeting. And so in Latin America there have been times where it's like, well, maybe this just isn't working, but the people and from the MFIs who are doing health and microfinance say, no, we want this to work, we really want to figure this out. But I think that there's not necessarily a magic potion to making it work out. It's really understanding the expectations of those who are coming together, how to make it worthwhile, and then how to divide up the responsibility of getting people together. Because, you know, someone like Freedom from Hunger, the Microcredit Summit Campaign, we can rally initially, but we're not the ones working right there implementing in the country. So it really has to, I think, for sustainability, really live within a group or one MFI. And so
We can initiate the action, but I think it has to be carried by the members
exactly.
themselves. Alex, when Equitas agreed to our request of taking leadership in mobilizing the microfinance sector, we were really excited about it, and we would like to know how you could contribute to establishing this community of practice in India. Or how do you think Equitas can play an active role?
Yeah, before I talk about the how, the reason why we started should also be answered, because one of the data says that one of the major reasons for over-indebtedness among the underprivileged is health. You know, this family is slowly growing step by step, and suddenly a major illness hits, especially the mother, and the entire thing comes down. And they have to borrow because it's an emergency, it's an unforeseen expenditure. So we found that health was a key pain point for them, and we started studying how to go about it. So that's how we said this is a major pain point that we need to address and cushion them. And then when we looked around, we found a lot of, and we couldn't do it alone. We have no doctors in Equitas. What we saw, like Marilyn said, was partnership. Partnership was the answer. There were hospitals who wanted to come around and screen. And in India, every hospital which has more than 20, 30 beds imports a lot of equipments. And when they import, there is a custom duty, which is waived if they say they will do 20 to 30% for the poor. And they didn't know how to locate the poor. And Equitas, we had the huge client base. So it was that much easier for us to connect with these health providers. And we said, all you have to do is come with the team. We will assemble the people. And it was so much easy. But there was a cost. So we said, we'll bear that cost. At Equitas, we have about 500 branches. So 500 camps happen every month. And about 80,000 people pass through these health camps screen.
Every month?
Every month. And the hospital saw a huge potential here. And they said, why don't you send these people, if they want special treatment, serious ailments, come to the hospital. Then I said, like Marilyn said, rightly said, was, can you give them a discount? Because volume is there. You have more footfalls in the hospitals. And then they agreed. So the second model of referrals came. First was the field camps. The second was the referrals. The third was, very often during an emergency, the low-income households don't know where to go. In fact, I know of a person who called me at 1 o'clock in the night, said, there's a kidney problem, which doctor should I go? Very often we have this, who's the best doctor? So we started a health helpline to guide our customers to go to the correct hospital. A reputed hospitals will not take them for a ride. So we started the health helpline. Then came help from Freedom from Hunger, preventive education. So every month we train about 5,000 women in identifying early methods of detecting blood pressure, sugar, breast cancers, and cervical cancer. In fact, a recent study which I have shared with the Freedom from Hunger is the knowledge level was about 5% in the beginning. Post this training, the knowledge has gone about 85. Now they know inhaling smoking is also a serious issue, because they didn't know. They said it was okay.
The healthy habits model.
Healthy habits model that we introduced thanks to Freedom from Hunger and Microcredit Summit, which we partnered with. And now we said, okay, there was another issue. Now we started our own clinics in the evening. Now this, from end-to-end service, preventive, screening, and then curative, is a beautiful model that we have developed, and I think this is high time that we use the, open it up to all the other players, because we have some strength, the government has strength, other MFIs have strength. Together we can make it happen. That's why I believe COP is the answer for India, and Equitas would be happy to do whatever role, whether it's leadership role or follower role, a role. We'll be happy to be partner of this.
It will be interesting actually to document, what Equitas has been doing. Some outside person looking at it, and how do clients perceive the value. Of course, they already have done some sort of a study, but in a more comprehensive way. I think that will be a good learning for other microfinance institutions also.
In fact, we did a small study, and in fact, N. Srinivasan, who writes the State of the Sector, did it. Very often we call it the bang for the buck. Bang for the buck. So, for the same health service for a screening, if a vegetable vendor, my client, has to go in search of a doctor, the opportunity cost, the transport cost would be about 25 times more than what we are able to provide. So the bang for the buck is 1:25. So for every rupee I spend, the value that the client sees is 25. That is for the screening. For the health intervention or visit to the hospital for inpatient treatment, it is much more, because they get a 50% discount. And we have, even for open heart surgeries for the children, congenital diseases, it's a free treatment. We partner with the government there, especially in the state of Tamil Nadu, has a beautiful comprehensive health insurance scheme with reputed hospitals.
Yeah. Paul, ESAF has been actually promoting health for a long time. You ran hospitals, and then health education was there, and clinics were there, and community health workers were there, and you did face a lot of challenges in scaling them up and in continuing them. How do you think the role of a microfinance institution in promoting health, and should microfinance institution be only talking about financial products, of health related financial products only, or they can also look at awareness building, education, and linkages? What do you think the role, and also how do you look at ESAF moving in the next 4 or 5 years in this line, particularly in the context of ESAF becoming a small bank now? I don't know whether you step back now and concentrate more on your financial products, or you continue to be giving importance to health. Really curious to know.
Yeah, ESAF started as an NGO. So health was one of the, along with the enterprise development and financial services, health, community health was one major department. We have been doing it in the NGO. Then the microfinance arm has grown, so we have separated that. But ESAF has been believing in an integrated development model, and we see microfinance as a platform for integrated development. So we try to integrate health, try to integrate education in the microfinance platform. So that was, we have been doing that from the beginning.
From the beginning,
That was the approach. Then see, as the program grows, integrating the health and other development components with microfinance has become a little challenging because of the cost aspect. Because we need to, as an MFI, we cannot. The lending rates are capped, and we cannot change that even if we are providing an additional service to the clients. So even then, so we focus on creating awareness, community awareness, many especially healthy habits. So I think in this juncture we partnered with Microcredit Summit Campaign and Freedom from Hunger, and we introduced the health awareness programs. We trained our staff and also community health workers, and especially the primary health healthy habits, the importance of hand washing, and all those different modules we have introduced. Then latest we found that in the rural areas we wanted to bring doctors to the we have been, as Equitas has been doing, we have been doing camps and all. Then later we found that why don't we create health entrepreneurs from within among our clients. So we called a program called Arogya Mitras. So we trained, we did a pilot by giving training 10 Arogya Mitras. I think Johnson & Johnson supported us in that venture, and that's becoming, so they do the awareness, they do they go to the villages, they do the
blood pressure and blood sugar
pressure checking and blood sugar checking, and also some of the health tips also there.
Messages,
That model is becoming, we wanted to scale up that model. That's one thing. Also we wanted to share these learnings with other microfinance institutions, and also bring in health institutions also to this platform.
That is the key. That is the key.
So that slowly they have started understanding the strength of microfinance. So we have to work together to bring the health providers to the microfinance platform.
See, when this COP progresses in India, it's important that each of the microfinance institution brings ropes in with whom they are already partnering. The health sector, with they are already partnering, they should be involved, so that we become a sort of a.
I think we need to do together. We need to do a lot of advocacy and marketing to convince the health providers, health institutions about the potential in associating with microfinance institutions.
I have got a fairly good response from the health sector. Now I have started going about and meeting them and making presentations and making them see that microfinance institutions are capable of doing quite a lot. So that has begun. Sometime in August, we are planning to have a big stakeholder meeting where we will have about 15-20 MFIs and 15-20 health sector people, and that platform will become very crucial for future. That will be the foundation.
Okay, finally, to your last question. So even if we become a small finance bank, the mission is not going to change. We will continue to provide, continue to focus the bottom of the pyramid community, the underserved communities, and with not only with financial service, we will be focusing on the livelihood, health, education. So it will be an integrated model only.
Very good, very good.
If I have to echo Paul's statement on, Equitas also has got in principle, approval to become a small finance bank. Again, the small is there so that we don't become the big sexy banks. So we will be with the small entrepreneurs, and we will continue to do handholding of this with all the social initiatives, and probably a little more, because as a bank I can probably sell a very affordable medical insurance product now, and don't have to look up to others. So it actually gives us a huge strength where I
to
can
innovate
and bring them on a safety belt.
Yeah, when I was coming here, I think Paul and Alex were asking whether the COP is for India or it's only for Philippines, and what about at a higher level. So I was just telling them that we are experimenting in India, Philippines and Andes, and maybe at one stage, at one level, it will be a global movement, and that is our ultimate goal, and hopefully it will work out.
Yeah, and I do think that the different COPs can learn a lot from one another. I think each one is going to be a little bit different according to those who are a part of it. So hearing some about advocacy, that definitely, if the members are interested, could be a big part as advocacy maybe to other MFIs, that adding health is a good thing and why and how do you do it, or maybe it's advocacy to the government as a good development strategy to mix the two. So advocacy, if up to the members in that, can definitely also be an important thing. And I think with the different COPs, remembering that you can be creative is also really important. I mean, one idea that I don't think it's necessarily come to fruition in Latin America, but there is the idea that, well, maybe if you've got core members within a COP, they together could go in for funding to do a big project or something. So really, the sky's the limit on different things you can do depending on what people want to get out of it.
Actually, it occurs to me when we are going to start the webinars from the next month, the first webinar, and why I should restrict it to only Indian players. I mean, we can always invite CARD's COP members of the Philippines to join the webinar, and that will be much more.
People working with the low-income household, I would always ask this question: do you want a healthy borrower or a sick borrower? What would you prefer? You want a healthy borrower, so make them healthy. So it is a win-win for the microfinance organization also. It's a very positive note that I would like to add here.
Particularly, I see a lot of need for innovation in health financing. There's the need for more of health insurance and health, however complex it may be. I know it's very, very complex to run a health insurance product. It's probably the most complex thing to do, but it is so badly needed. Health loans.
The future I see is also taking health beyond the walls of an hospital, because I think Marilyn also quoted earlier that taking health, like microfinance has been a success because the key differentiator between a bank and a microfinance, we collect doorstep. Now, I believe any business that you do with them, a social business, will be successful if you can take it to the doorstep. And I believe technology is going to help us. Telemedicine, and if you can take if a mobile can connect a patient with a doctor, I mean, that's the dream that we should all have.
Yeah, so our COP should focus on that aspect a lot. Good, thank you very much.